Thank you for your introduction. Dear Professor Spinarova, dear Professor Pignatelli, dear colleagues, I would like to welcome you to my presentation about hyponatremia in acute heart failure. It is well known that acute heart failure is associated with multi-organ dysfunction that often leads to electrolyte disturbances. And the most common electrolyte disturbance found in hospitalized patients is hyponatremia. According to previously published studies, hyponatremia has been shown to be associated with poor clinical outcomes in patients with acute heart failure. However, the value of hyponatremia as a marker of adverse outcome, independently of other predictors, patient characteristics, and the prevalence of hyponatremia in patients with acute heart failure is still largely unknown. For this purpose, we use the Basel V study. Basel V was a prospective multi-center diagnostic study that enrolled adult patients with acute dyspnea presenting to the emergency department. In the current study, we included only patients with a final diagnosis of acute heart failure. Our primary endpoint was all-cause mortality at 180 days post-discharge, and our secondary endpoint was defined as a composite of all-cause mortality and heart failure readmissions at 180 days post-discharge. Patients were categorized into 3 groups according to the baseline serum sodium levels, and namely to hyponatremia, defined as serum sodium level of less than 135 millimole per liter, normonatremia between 135 and 145, and hypernatremia more than 145 millimole per liter. Moving on to the results. After excluding patients with missing values and no follow-up, we had in total 1,499 eligible patients. Among those, 14.3% had hyponatremia, 83.3% had normonatremia, and 2.3% had hypernatremia upon admission. In total, at discharge, there were 9.9% of patients with hyponatremia. And among those presenting with hyponatremia, 4.5%, which makes 1/3 of patients, remained hyponatremic at discharge. You can see the part of the baseline characteristics table on the slide. And results demonstrated that in hyponatremia group, in comparison to normal and hypernatremia groups, there were significantly more female patients, more patients with lower systolic blood pressure, more with chronic liver, prior history of liver disease, but less with chronic kidney disease. Also, the infection as a trigger of acute heart failure episode was also observed more in hyponatremia group, and patients had higher levels of C-reactive protein levels. There were no significant differences between groups in age, in NIHA class, in chronic heart failure, ischemic heart disease, in T-proBNP and GFR levels on admission. Our results showed that patients in the hyponatremia group had significantly longer duration of hospitalization in comparison to normonatremia group, but shorter in comparison to hypernatremia group. And the median length of stay was 12 days for hyponatremia group, 10 days for normonatremia group, and 13 days for hypernatremia group. As you can see from the Kaplan-Meier curve, the all-cause mortality rate at 180 days post-discharge was significantly higher for hyponatremia group in comparison to normal and hypernatremia groups. Event was observed in 25.1% of hyponatremic patients. Moreover, to assess the independent relationship between sodium status and clinical outcome, multivariable Cox regression analysis was performed. Included covariates were age, sex, infection, ischemic heart disease, chronic heart failure, systolic blood pressure on admission, NT-proBNP, and glomerular filtration rate on admission. The hazard ratio for mortality in hyponatremia group compared to the reference normonatremia group was 1.62. The composite of all-cause death and heart failure readmission at 180 days as well showed a significantly higher event rate in the hyponatremia group. The event was observed in 36.7% of patients with hyponatremia, and the hazard ratio was 1.49. All the results were statistically significant. Our study had some limitations. First of all, findings are specific to patients who present to the emergency department and are stable enough to give consent. Patients with terminal kidney disease were excluded from our study and cannot be commented on. And lastly, only sodium levels upon admission were included in survival analysis. So in summary, according to our findings, the prevalence of hyponatremia on admission was 14.3%, among which 1/3 remained hyponatremic at discharge. In total, 9.9% of patients had hyponatremia at discharge. Moreover, our study demonstrated that hyponatremia upon admission is associated with higher risk of mortality and heart failure readmission in patients with acute heart failure and should be taken into account for risk prediction as an independent marker of a worse outcome. I would like to add that these are only preliminary results, and our research on sodium is still going to expand. Thank you for your attention.
So thank you very much for the presentation, and the paper is open for discussion. There is one question.
Hi there, thank you for an excellent talk. You had said that patients who have hyponatremia are more likely to have infection. Do you think that there could be other causes of hyponatremia other than heart failure, infection, malignancy, other causes of SIADH that could be driving it here, rather than just acute heart failure?
Of course, hyponatremia is a multifactorial entity, and there could be other causes. I just demonstrated our results, and unfortunately cannot say the etiology right now.
Thank you. I would like to ask you, do you have any data about medication of these patients where there are differences, for example, in the usage of loop diuretics in the patients with hyponatremia?
Yes, I have a slide in appendix. Actually, we compared patients by medications on admission and at discharge. And there were no significant differences between groups by loop diuretics, but there was a significant difference on admission. Patients in hyponatremia group had more, took more spironolactone upon admission than two other groups. So that was the only difference.
Yes, thank you very much. There are no more questions, so thank you again for the presentation.
Thank you.
And